Hey everybody, just sitting in the backyard with the dogs, enjoying some of the nice weather. We've had a pretty brutal summer here in the Central Valley, so take advantage of the cooling down period before we get into the crap. In the Central Valley, we kind of have we have 2 weeks of good weather in the spring and in the fall, and then it kind of goes to pieces. Anyway, I was thinking a little bit more about the monoclonal antibody situation. I was a little bit curious. Some of the stuff going on right now around the COVID pandemic in terms of research and development, plainly speaking, in terms of pharmacy, it's kind of interesting. The drugs, the virus itself, the disease is a terrible thing, but from just a pharmacology perspective, some of it's very interesting. It reminds me a little bit early in my career during the AIDS epidemic. There was a lot of research and development going on around HIV medications at the time. I know, like I said early on, there were 2 or 3 HIV medications, and then it kind of boomed. And now there's a ton. I don't even know anymore how many there are, but things became quite different. The one thing to drive research and development in the pharmaceutical industry, of course, is money. I don't think there's any altruistic rationale behind some of the drug development. Clearly money talks. Regardless of what you think of number 45, the warp speed drug development that his administration did is significant, especially when you think about the 25 years that I've been a pharmacist. I've never seen anything quite like that. So it was impressive, no question about it. Anyway, I pulled some data, some information regarding the monoclonal antibodies. These are specifically the Anti-SARS-CoV-2 monoclonal antibodies. These are the ones that you give people early on when they first have symptoms, to prevent them from the disease getting worse, or possibly in some cases prevent them from getting hospitalized, or etc. Anyway, if you know what I was mentioning before about monoclonal antibodies, you have the antibody. This is my antibody, light chain, heavy chain, and it binds to the cell and basically prevents the cell, in this case the virus, from doing its thing. In this case, it binds to these particular ones. They bind to the spike protein, the S protein, and they prevent the S1 subunit of the spike protein from binding to the ACE2 receptor. And in theory, it prevents them from getting busy and replicating and doing all the things that the SARS-CoV virus does. So anyway, there's 3 of them. This information is available at the NIH website. It's nothing secret. Just basically Googled monoclonal antibodies, COVID, went to the NIH site, and there's pretty good document there. Some good information if anybody's interested. But basically, they list 3. They've got crazy names. Bamlanivimab plus estisevimab. I'm not familiar with that one. The one I am familiar with is the next one. It's Regen COVE, and that's the casirivimab and imdevimab. That's the one that is kind of made famous by DeSantis in Florida. He's been pushing that one pretty hard. And then there's one called sotrovimab. Also not familiar with that one. And anyway, if you look at this information, it gives you kind of like a rundown of why you would want to give the anti-SARS-CoV-2 monoclonal antibodies. And basically it says the use of the anti-SARS-CoV-2 monoclonal antibodies products reduce the risk of hospitalization and death. And then it refers you to Table 3. Now, Table 3 is interesting because it actually gives you some of the randomized controlled data for these drugs. And I'm going to specifically look at Regen COVE because this is the one that I think we should probably be using, especially in California. I've been very disappointed in California's lack of adoption of these monoclonal antibodies. You don't see them given very often. In fact, you really don't see California utilizing any of the treatments that are available to us. I mean, they're pushing the vaccine hard. I mean, basically, I'm mandated to get the vaccine because I work in healthcare, or weekly get threatened to get fired. But in terms of using treatments available for the disease itself, I don't see much of that, besides remdesivir, which has turned out to be just a turd. we use a ton of remdesivir, but honestly, the data for it blows. Anyway, let's take a look at the Regen COVE in here, and they list the results for absolute reduction and relative risk reduction for this particular monoclonal antibody. And I wouldn't put too much stock in the relative risk reduction. I don't like that number. To me, it doesn't make a lot of sense. It sensationalizes the data. So, for example, if you had 1 in a million that died, and you gave somebody a drug, and now only 1 in 2 million died, that'd be this massive relative risk reduction. You basically doubled your odds of surviving, but that's really not the case. It's actually a very small percentage of survival increase based on the absolute reduction. So if you pay attention to the absolute risk reduction for these medications, it's not great, but it's not really bad. Basically, for COVID-related hospitalization and all-cause death through day 29 using this particular medication, in the control group, you had 7 of 736, so 1% in the arm that received the Regen COVE group versus 3.2% in the placebo arm. So you had about a little over 2% absolute reduction. And then in terms of all-cause deaths, you had about a 3.3% absolute reduction in COVID-related hospitalization and all-cause death in patients who received the big dose versus those that received the small dose. So basically, the small dose is the winner here. The small dose is the 600 milligram of one and 600 milligrams of the other. The product early on came in 2 different vials, but now it comes in a single vial. It's a straight draw. You shoot it into a bag, infuse it over an hour, and it's no big deal. But anyway, I would highly encourage anybody to that's watching this, all 2 of you, to go to the NIH, take a look at this document. It's pretty interesting reading. I mean, from a pharmacist standpoint, it's kind of interesting stuff, and I would expect to see more of this. There's actually a paper, I mean, if you're really interested, there was a paper that was published online. I believe it was in June, but it came out officially in I think August, just last month or a couple months back, in Biochemical and Biophysical Research Communication. There's actually an article in there that talks quite a bit about all of the monoclonal antibodies that are available, and kind of the theory behind it, and the theory behind using cocktails, and where the binding sites are. Obviously, there's different binding sites, and I think that's some pretty interesting stuff. And I think in some of the more progressive states, we may start seeing some of the combination of these products, to get on top of the disease before the patient gets hospitalized or before the symptoms become worse. That's my dog. My dog's over there protecting us from some unseen adversary. She does that a lot. She's very good at it. Anyway, that's all I have to say for now. Thanks for watching, and go read about monoclonal antibodies. Take care.